I've read, the notes and the description of what happened, but I just wanted to hear in your own words what actually happened back in June.
Well, it was a small stroke. Just finished having lunch, washing the dishes, and yeah, everything just went a bit wonky.
Okay. So how did it actually affect you? What did you?
What at the time?
Yeah.
It was loss of control at the left side of my face.
Okay.
Couldn't speak properly, and I lost control, a lot of strength in my left hand.
Okay. Has it fully recovered, do you think?
Pretty much. Occasionally still trip over a few words, like if I've not said them since.
Me too.
Yeah, like some words if I haven't, like complicated words I haven't said since the stroke. It's just kind of like relearning.
You have to think about things.
Yeah,
well, doesn't it?
you practice a little bit and then it's fine.
And how long did it take roughly to kind of start to notice, a big recovery? So most of your symptoms had resolved. What kind of time frame?
It was fairly quick to be honest. Maybe like 3 to 6 months. I mean, a lot of the fatiguing was gone by about sort of 3 months. I was still tripping over words for about another 6 months, and I still do a little bit.
Okay. Some people get better within just a day or two, but with you it clearly took a bit longer than that. Okay. And you hadn't done anything particularly out of the ordinary, unusual in the days leading up to the stroke?
Nope.
No pain in your leg or swelling of your legs?
No, nothing like that.
And there hadn't been any long distance travel or anything like that?
No.
Okay.
No.
The one thing I noticed in your history that might be relevant though is I think you've had migraine.
Migraine,
migraine.
You have migraine maybe 2 or 3 a year. Okay. I get the kind of aura, it closes in.
Yeah.
Then all that goes away. I've got about 15 minutes where I feel fine, and then I just get the head.
Okay. Is it usually one side of your head?
Yeah. And then that lasts for anywhere between a day to 3 days.
Okay. So that's very classical migraine that you're describing really, and that's linked with holes in the heart as well. Whether that will get better or not after we close it is a bit of a moot point. It's unpredictable. Some people even notice it gets a bit worse just in the initial few weeks after putting a device in the heart. But after that, once the device starts to heal and your PFO is closed, you may find that your migraine's better. But it's rare for this procedure to cure it. Okay. So if there are specific triggers like red wine and things like that, they'll probably still continue to be triggers for your migraine. But some other triggers might get better. But we'll see. I'd be interested to see. So, as you know, the investigations that they performed up in Aberdeen, they didn't find any other cause for your stroke, but they did find a hole in your heart, and it's this thing called a PFO, or patent foramen ovale. In your case, it's relatively large as these things go. So we measured a hole of about 7 millimeters or so in your heart, and in this situation, when it's not very big, but in these situations when it's relatively large, we will often, and there's definitely no other cause for your stroke, we will recommend closing it, and I know that you were keen to go ahead with that. So the procedure today will be performed under general anaesthetic. I think you've met the anaesthetist already. Yeah. She'll explain that aspect of it to you. The main reason for that is we want to do the transesophageal echo again, which is when they got you to swallow the tube down. And I know you were conscious when you had that done last time, but this time we'll also have a catheter in your leg. And it's very difficult if people got a tube down your throat at the same time. It's very hard. And we also need you to lie still and relax. And so that's why an anaesthetic is used. The catheter will also put some anaesthetic in your leg, so you won't be sore when you come round from the anaesthetic. And it's just the vein that will be puncturing in your leg. And the catheter goes up through the hole in your heart. I think in your case it'll be very easy to get a catheter across this because it's relatively large. And we're going to implant then a little device through the catheter. The catheter is quite fine, it's about the width of a biro. But the device that goes in, I've happened to have one here that I made earlier. And this is what we're going to implant. And you can see it's got a disc which will go either side of the little hole in your heart. It's absolutely not.
Okay.
The hole in your heart is not that big, but the device is quite a lot bigger than the hole. Yeah. And the reason for that is because one of the potential complications of this procedure is the device can fall out, and this is called embolization. This comes in different sizes. It comes in a range of sizes. I think this is a 25mm device, and I think that's likely to be the smallest that we would use in your case. I think this is very likely to be the one that we will choose actually. But that's, I think that there's one size smaller, but I think that would be too small in your case. So we oversize the device so that it can't, and we make sure it's very secure, so it can't pull through the hole. Because it's very flexible. As you can see, it's made of a metal which is very, very springy and flexible, and it springs back into shape. We have to be certain that we can't pull that through the hole, so in which case it could fall out and embolize, and it would be free in the circulation. It could end up anywhere. It often ends up in the lungs. But that's a rare complication because we check to make sure that this is very secure before we release it. It's on a cable. If it's not secure, we can remove it and put in a larger one until we find one that is secure.
Sure.
Okay. There's a very small risk of infection with this procedure. If the device got infected, it could be serious, and it would have to be removed. But we give you antibiotics to prevent that, and that's a very rare complication. And occasionally we get some bleeding and bruising from the leg. Again, this is an uncommon complication. Overall, anything going wrong with this procedure, the overall risk is well below 1%. So it's a very
my
low
heart
risk
will
procedure.
grow over that then?
It will.
Sweet.
So a new lining will eventually grow over that. Now, we know that takes at least 6 months.
Right.
So we'll chat a little bit about your medication, but you've been given some blood thinning medication, haven't you?
Yeah, on the clopidogrel and the statin.
Yeah.
But
okay. So with the blood thinning medication, we'll give you a little bit of additional blood thinning medication. It's just simple aspirin, which you can take together with the clopidogrel, but we generally only give that for 6 weeks after the procedure.
Okay.
And we'll ask you to stay on the clopidogrel. And if you're fine on it, and I think you have been fine taking clopidogrel, you felt okay on it. So
yeah, I'm fine.
It also has an anti-migraine effect, which might benefit you. So I think the best, although it's not licensed for that, but I think the best thing might be for you just to stay on clopidogrel indefinitely.
Okay.
The statins are commonly given to people who've had strokes because most strokes are caused by narrowing in the arteries in the neck here. And this is cholesterol deposits that people get in the neck. But we know that your arteries were completely normal. Yeah. And I think your cholesterol level was quite low.
Yeah, pretty low.
You told me it was about 4, I think.
Yeah, it was 4. Yeah, 4 point something.
I think that's what it was. It's 4 point something. So that's actually quite a low cholesterol level. And we also know there isn't any cholesterol deposit, so there aren't any cholesterol deposits in your neck because that was all imaged with the MRI scan that you had. So this blood clot that caused your stroke probably originated from one of the veins in your legs. So blood thinning medication is very important to prevent blood clots, but cholesterol medication probably doesn't have any benefit in this situation at all.
Okay.
So I think you should stop taking the statin. You're really not going to benefit from it. People do Valsalvas in normal everyday things. If you cough or sneeze, they're minor kind of Valsalva type things. So whilst people give that advice and it's well-meaning, it's impossible to avoid these things altogether. But it would be sensible not to do anything that would involve a lot of pushing and straining, like weightlifting again for at least a month, and again go back into it gradually. Yeah. Okay. But if you leave it for at least a month, this will be starting to heal, and it will be more secure after a month or so.
Okay. So the paranoid person in me wants to know, you know, it's like, will you do a follow-up, like esophageal, to make sure that that's not?
Good point. So we just do a normal scan of your heart. We can see the device very clearly on a normal echo scan. We don't need to do the transesophageal scan. But we should repeat the contrast scan. So we will always do a follow-up contrast scan. That means injecting the bubbles in your vein again. So it's a bubble echo. And we do that routinely after about 3 months or so. So we give it a chance to heal over first because it does take a while for this to seal. And so we would schedule a bubble test in about 3 months. I don't have to bring you back here for that. They're very experienced in doing that in your local hospital in Aberdeen. So they'll do that. They'll do that up there.
Cool.
And I should warn you that about 10% of people somewhere between 5 and 10% of people who get this device implanted will still get a few tiny bubbles going through it. Your bubble test was extremely positive. There were hundreds, and you couldn't count the number of bubbles. But and I'm sure it'll reduce that a lot, but occasionally people find just a few bubbles still go through. That does not mean the device hasn't worked, because it will still stop blood clots getting through. So if there's just a handful of little bubbles getting through, we don't worry too much about that. And about 5 to 10% of people we do find that. But this device is probably as good as any.
Sure. So
in that regard.
if it doesn't fully seal, like you say, like maybe, you know,
Well, it's designed to stop blood. We hope it will fully
Yeah,
seal first.
yeah.
But it's designed to stop blood clots, and that's the important
all right,
thing.
cool, yeah.
And these bubbles that we inject are very, very tiny. Some of them are very tiny. They're almost they are microscopic. Some of them, and they can get through the tiniest little thing that a blood clot couldn't get through.
Cool.
So if it's just a handful of tiny
Yeah.
bubbles, we don't worry about
Yeah.
that too much.
Because they're teeny. Awesome.